which are kind of unneeded for this whole ecosystem from all experts. Hey, Dr. Farrago, how are you?
Good.
Perfect. Good to see you.
Okay. Hello, everyone. I'm Ameena. I know I have not met most of you. As Dr. Ahmed said, we didn't have a chance to have a pre-meeting. We're really excited about this dialogue, about this panel, and so looking forward to everything that you guys have to share.
Sounds good.
And so we have Sherri Johnson, who is the VP of the American Telephysician. Ameena is the CEO of the Blue Ridge Consulting Company. Amazing partner for us, and they have the stakeholder United Nations, and then Monique is based in California. She has been senior investment banker at IFC, the World Bank Group. I know Monique for quite some time now. I had the opportunity to meet her at the World Bank Digital Health event, and we are waiting for our two other participants. One is Dr. Skapik. She is the director of the National Association of Community Health Center. And then Dr. Gadir, he is going to be joining from Dubai. He's their international director for IQVIA. Let me see there. So let me just quickly, while you guys have any questions, please let me know. Let me just quickly text Dr. Gadir too. Sherri, will you do a favor to me, please? Can you, I don't know if you have Dr. Skapik's email there, which she replied. Let me see.
Let me take a look.
We may just need to call her office to make.
I do have an email for her.
So, Dr. Wohlfeiler, are you? Where are you? Are you still in California?
Yeah, I'm actually, based. I mean, we're headquartered in Los Angeles, but I'm based in Miami, so I just do a lot of traveling back and not so much.
Okay, so you're
starting again. Yeah.
You are okay. So we are.
Dr. Ahmed, I just got a note from Dr. Skapik that she needs the Zoom link.
Okay, it should have been resent to everyone just a couple of minutes ago. Let's just check on that. Let me see if I can resend it.
Okay.
If she's anything like me, I was not looking in the right place. I was looking look for emails from Sherri and things like that. And then I finally thought, oh, maybe I need to look for emails from Zoom. And that's where I found mine. So she may not.
Okay.
Oh, you're actually right. Thanks for pointing out. In the future, yeah, I think we'll just copy
we'll
that
keep it
link.
Consistent.
Yeah.
Right.
Maybe that's the same case with Dr. Gadir too. If Jocelyn is on the call.
Jocelyn, can we resend everyone their links one more time, please?
And Dr. Farrago, where are you based today?
I'm in Virginia.
Virginia. Okay, got it. Monique, I know you're in Canada, right?
I'm sorry.
Oh, Monique, sorry, I was asking.
Yeah, I'm in quarantine. I'm on day 8 of quarantine.
Oh.
Okay, so Dr. Skapik is here.
Hello, sorry I'm late. It's Julia Skapik.
Hello, how are you doing, Dr. Skapik?
I'm just.
So quickly overview, because we will be going live in 4 minutes, and not only on that portal, but also on various social media channels and the YouTube channels as well. So I just quickly want to recap the format. Ameena is going to start the conversation and this webinar. will be opening remarks and about the United Nations goals and the reason we are doing this event. I will be then talking about why we chose primary care as the prime focus on this for this event. And then I'll be obviously introducing very briefly the participant. The main introduction will come from each of you. And I'll ask questions given the time constraint. Unfortunately, we only have 1 hour session. So we will be, I'll be doing 2 rounds of questions. 1 round is, as you have seen, the question is focused on asking the questions about your organization and their role in primary care. And some of the briefly some of the challenges, and one of the big challenges I think for all of us will be the time management. So hopefully we'll be able to do that. And in the second round of questions, I will be asking about the digital health and how do you think digital health is helping your own organization's goal and what are the barriers there. And then after the discussion, I'll be also sharing some of the thoughts about what American Telephysicians thinks and what the connected healthcare model is. And then we'll have questions from the audience or those participants. Sherri will be going over those questions there. Dr. Skapik, can you hear us? We cannot see you. If you don't mind, do you?
Oh, yes. Sorry. Oh, yeah, I can turn that on.
I believe Dr. Gadir, don't think he.
Waqas, I think we are live now at this point.
Okay. Let's Dr. Skapik. Let's get waiting for Dr. Skapik to join. So we've got 2 minutes.
I'm here.
To start. Oh, I guess Dr. Skapik, do you have a video by any chance? We cannot see
I
you.
do. We're actually pulling over so that I can speak. We were traveling today and got a little bit behind schedule, but
Oh, okay.
I can turn it back on.
Thank you. Okay. All right. Got it. Okay. Sure. So I think to keep Ameena, how is going to be the only the person who's speaking or the moderator going to be unmute, other will be muted and then add respectively. So keep the okay.
Absolutely. Cecilia, do you want to run through that with us real quick if you're on the call?
And Dr. Gadir is, I don't see him on the panel list. He said, I am in. Did he get the panelist link?
All the links were sent from Zoom just a few minutes ago. Let's see this. Technology is, is hit or miss, I know.
Okay. That's okay. So we'll actually have this. If you see the chat box there, that's where he said there. So maybe Jocelyn can send him or coordinate. So we'll start. Okay. All right, Ameena, I think it's 1 o'clock. So we can start.
Okay, I'm just making sure he's. Technology here too, trying to make sure he gets in from the wait room. Okay, I think we should start. Good afternoon, delegates, esteemed panelists, and participants. My name is Ameena Zia. I am the founder of Blue Ridge Impact Consulting, a social impact firm working across private and public sectors to ensure stakeholder approach to development. I have been engaged at the UN for quite some time now. This event is extremely important for us today because it highlights the challenges that COVID-19 has brought to us. Excuse me, just 1 second. I'm sorry, I'm getting a message that he is not able to get in. And I just want to make sure all our panelists are in. I am so sorry.
He is there. I can see him.
We can see him.
Yep, he's just joined us. Dr. Gadir is mute. Yeah, he's joined us. Good.
He's joined us? Okay.
Yep, I can see him. He's with us now.
Okay, just one moment. Okay. Okay, again, all right, let's just continue. Good afternoon, delegates, esteemed panelists, and participants. Again, my name is Ameena Zia. I'm the founder of Blue Ridge Impact Consulting. We're a social impact firm working across private and public sectors to ensure that we are introducing stakeholder approach to development. A lot of our work is rooted around Sustainable Development Goals and the Agenda 2030. I'm very excited about this particular dialogue and engaging with all of our stakeholders today, because it really will help drive the conversation around what does access to healthcare look like, and who are the gatekeepers to healthcare, and how can we reimagine this space? And we do that by engaging in very robust conversations and dialogues with our stakeholders within our communities and our professional spaces. As a social impact firm, we are also rooted in the UN Global Goal 17, and today's event is specifically centered around Global Goal 3, which is health and well-being, and Target 3.8, which is access to essential health care. So as we work through frameworks, as we work through our own development capacities, it's important for us to understand that, you know, the pandemic, the COVID-19 pandemic has highlighted and exacerbated the inequalities in our communities. The launch, I would like to mention, of the Decade of Action and the Delivery for Sustainable Development in 2020, which is part of the United Nations discussions, outlined that over the past week, during the high-level political forum, recognizes that the world has a limited time to meet those goals that I discussed. And of course, we are all experiencing you know, the aftermaths, or we're still in the COVID-19 experience. And it has been called the most challenging crisis humanity has faced since the Second World War by the UN Secretary General. We have all witnessed adverse health and socioeconomic impacts for societies around the globe. And we know that the pandemic has further exacerbated conditions for those who are most marginalized. So that's where we find ourselves today. Well, where do we go from here? Because of course, all of this is a concern. And the pandemic has also revealed the deficiencies and vulnerabilities, I would like to add, of our current systems. And there is an emphasis on the need to build effective structures that enable cooperation, that enable participation, structures that are representative in nature to meet the rising inequalities. So of course, the pandemic has also revealed discontent over how power is distributed. And we know that the use and oversight of power determining people's well-being is key in understanding, of course, the centralization and the consolidation of power, which in turn diminishes the trust in systems and of course shrinks the space for engagements like the ones we have today. So today, in line with the focus of the high-level political forum for the 2021 on sustainability and resilient recovery, this forum brings together scientific evidence, it brings together technological practice and healthcare professionals to advance the progress of sustainability goals and of course of Target 3.8 of access to quality essential healthcare, as I mentioned earlier. And our dialogue today is structured so that we are able to share advanced progress as potential solutions while living and going through COVID-19 pandemic experiences that reflect how the current context, devastating as it may have been for so many and continues to be, also provides a window of opportunity. It provides a leveraging point from which to steer systems transformations and to highlight contributions of the scientific and technological community to support transitions towards more desired outcomes, more equitable outcomes for all. And so with that, I look forward to a very constructive dialogue with our panelists who are change agents in their own spaces. Our panelists, keeping challenges in mind, are utilizing this particular window of opportunity for sustainable and also for just transitions and leading the way in reimagining our systems, specifically reimagining our healthcare system. Thank you. And I know now that our moderator, Dr. Ahmed, has a few words to share with us. He's also the founder and CEO of American Telephysicians. I would like to point out before I yield the floor to him that the American Telephysicians has been a stakeholder at the high-level political forum since 2019 and a member of the Sustainable Development Knowledge Platform. And as a thought leader in the space of healthcare innovation, American Telephysicians and Dr. Ahmed have been working for years to ensure access to all and quality healthcare to all. Over to you, Dr. Ahmed.
Thank you so much, Ameena, and thank you so much all the panelists as well as the viewers who have joined us through our social media channels and the live streaming websites. Welcome all. As Ameena mentioned, this event is about the access of healthcare, and the reason we chose the topic of today's topic, reshaping primary healthcare utilizing technology. When it comes to primary care, everyone knows that it's a cornerstone of the healthcare, but in reality it is kind of also an entire ecosystem, because primary care is not just, today's primary care is not just that one physician to doctor relationship, is an entire ecosystem. So I'm very pleased that we have been able to gather all the thought leaders in that space, because that ecosystem requires physicians and that they requires other service providers, technology, and of course the finance and the whole financial model to make it a sustainable ecosystem there. So I will go ahead and quickly introduce our respective panelists, and then we will proceed towards the discussion. I had a great pleasure to be with us, Dr. Michael Wohlfeiler. He is the Chief Medical Officer of AIDS Healthcare Foundation. AIDS Healthcare Foundation is one of the largest foundations in the world managing HIV patients, and they are essentially a primary care, running a primary care ecosystem for HIV patients with operations in 45 countries. We're very pleased to have a working relationship with them. I also had a pleasure with us, Monique Mrazek. She is the Senior Investment Banker and the IFC, the World Bank Group. And IFC has been one of the biggest players in the world, especially focusing on the emerging healthcare markets, and hundreds of projects they've been funded by the IFC. We have a player and we also have a player to join with us, Dr. Douglas Farrago. Very interestingly, he is and he will share more insight about that. He's one of the founding members of the direct primary care model in the US. We'll very much look forward to that discussion. We have Dr. Mazin Gadir. He's joining us from Dubai. He is the Director of Strategic Partnerships for one of a very large organization, IQVIA, which is a technology company focusing on healthcare data analytics with operations throughout the world. And our last panelist, Dr. Julia Skapik. She is the director of the National Association of Community Health Centers, providing the affordable cares to millions of Americans who do not have access to healthcare there. So with that, and then I have for closing remarks, Sherri Johnson, who is the VP of the American Telephysician. She will be taking care of the question and answers. My request to all the participants or those who are watching us from social media or on websites, they can post their questions. We will try to cover some of those questions, as many as we can. Our only limitation will be time, but hopefully our discussion will be around, maybe answer a lot of those questions there. So let me start the panelist discussion. Hope everyone is ready. Wonderful there. So I'll be starting with Dr. Michael Wohlfeiler with you. I know as a Chief Medical Officer and one of the founding members there, you're leading one of the largest primary care organizations for HIV patient, AIDS Healthcare Foundation there. It's a very unique model of providing primary care of patients with a specific disease, because obviously it's falls under specialty, but also primary care. Please give us some insight about this model and some of the barriers you have faced, especially during this COVID pandemic.
Sure. So, well, thank you for having me participate first. And so at AHF, we embrace a specialty primary care model. So what we do is what I refer to as HIV primary care. And traditionally in this country and many other countries, a lot of the HIV care has been conducted by infectious disease specialists. And they do a great job, but they often treat HIV as another area of consultative medicine. So they manage only the HIV itself, meaning the antiretroviral therapy, and then rely on the PCP to manage everything else. With a disease like HIV, that really is not a great way to approach it. HIV is not an organ-specific disease. It causes lots of comorbidities, comorbidities caused by either the HIV or the medicines used to treat HIV. So we find that a primary care model is much better. We want our patients coming to us if they've got the flu, and we manage a lot of the comorbidities associated with HIV, screening for heart disease and liver disease and kidney and so forth. One of the other things that I think is unique about AHF is that we really are involved in every part of the care continuum. We do more testing, HIV testing, than anybody else in the world. And if a patient tests positive for HIV at one of our testing sites, they're immediately assigned what's called a linkage counselor, who will walk them in, if necessary, to one of our clinics, and we get them engaged in care within 72 hours in one of our healthcare centers. We're very focused in our model of having making our care as patient-centered as possible, and trying to have one-stop shopping essentially for the patients. We have pharmacies embedded in almost all of our clinics, and they've got HIV specialist pharmacists who are running that. We're a large organization. I mean, we're taking care of worldwide about 1.5 million patients with HIV, and so we've got a lot of moving parts, and we, like a lot of places, had become too siloed. And so over the last year, we've embraced this concept of what we're calling radical cooperation. And it's made a huge difference in how we communicate across, departments and so forth. With regard to the barriers, I mean, probably the first thing that comes to mind is that our mission is to provide care for any HIV positive patient. And so that includes unfunded patients. So one of the first things we have to deal with is to see if we can ideally get them a payer source. And luckily there are programs like the Ryan White program in the US that allow us to get most patients on HIV patients on some kind of a care that is covered. But we still, we also provide a lot of wraparound services within our clinics that are usually not reimbursable, even under, for patients who have private insurance. So we have things like benefits counselors and case managers and social workers. And we use the revenue from our 340B program, which is a federal program that allows nonprofit entities like ourselves to purchase medications at a greatly discounted rate, and then we're able to get a bigger a decent margin on these medications, and all of that money pretty much is put right back into our programs. Yes. The other barriers that are chronic barriers with probably any patient population, but maybe more so with HIV, are issues of adherence to medication. HIV treatment requires a very high level of adherence to make sure that the virus does not mutate. Retention in care is a huge issue for us. We lose too many patients drop out of care, and that's something that we're constantly working on. Another issue that we deal with a lot is there's a lot of concomitant mental health and substance use issues with a number, a significant percentage of patients. And I think that the last big barrier I would say is stigma. And there is still stigma, both internalized and external stigma associated with being HIV. And that really impacts access to care and retention in care. And just to, our primary goal is to reduce as much as possible any barriers between the patient and us and their caregivers. So, yeah.
Thank you so much. Very elaborative. We will come back to those barriers, how technology can help this there. No, absolutely. Because as in COVID, I know we work with each other been working for telemedicine platform there. So definitely, I know that technology has answered to a lot of those barriers. I'll quickly come back to the Dr. Skapik, Julia Skapik. Julia Skapik, as a national director of the Community Healthcare Center, tell us a little bit about your organization and Community Healthcare Center model of primary care, and briefly about the current barriers.
Sure. So NAC, the National Association of Community Health Centers, is celebrating its 50th anniversary this year. And NAC grew up very quickly after the federally qualified health center movement in the United States. FQHCs are considered the healthcare safety net in the United States. So it's a place where you can go and get access to care regardless of your ability to pay. FQHCs also have a couple other interesting qualities, which include that 51% of the board or more has to be made up of members of the community and patients. Also, FQHCs have to provide essential services, meaning that beyond just providing healthcare services, federally qualified health centers provide things like access to food programs or food pantries. Many of them will do employment and education programs. Oftentimes, they help patients to sign up for social services, and they often provide vision, dental, and other behavioral health services in addition to just the medically traditional primary care services in the United States. FQHC populations, as you could imagine, therefore reflect sort of the needs and the qualities of the healthcare safety net. The majority of patients in FQHCs are minorities, and I believe it's 95% are at 200% of the federal poverty level or less. There is an increasing number of patients at FQHCs that do have insurance now, thanks to the United States expansion of Medicaid, which is low-income qualified health insurance. Nearly 50%, or maybe it might be just over now, actually, thanks to the pandemic, of our patients are on Medicaid. We also have a small proportion who are over 65 and therefore on Medicare. But a significant proportion of those patients still lack access to insurance, either because they fall into the income gap or because they're undocumented immigrants and their state doesn't offer Medicaid services to them. As a result, FQHCs have to be creative in their provision of services to different patients. Many of them have partnerships with different community organizations. For example, our FQHC uses Lion's Eye so that we can get our diabetics retinal exams. Many organizations have partnerships to get colonoscopies or mammograms and other screenings from partner organizations. During COVID, many health centers really rapidly switched. I believe over 99% of our health centers during the shutdown phase of the pandemic moved entirely to telehealth. And many of our organizations that had not been using telehealth were able to switch in a matter of a week. I know one of our large partners based out of Chicago said they did a full switch to telehealth in a matter of 5 business days. Telehealth for many FQHC patients means telephone health because they either don't have access to a device, they don't have the bandwidth that would support a device, they may not have the technical literacy to utilize a device for telehealth. So our health centers have been very creative also in how we support them. We have a network of migrant clinicians network, which works with migrant farm workers and agricultural workers, and a network that works with healthcare for the homeless. Those folks have been going out and setting up Wi-Fi hotspots for folks so that they can get access to the health center. We've been partnering with libraries or encouraging patients to even come and use the Wi-Fi of the health center, leaving that on even though the clinics were closed, and trying to help build up that technology literacy to support sort of the next wave of virtual care. About 25% of health centers were already using telehealth before the pandemic, but now that number is, remains above 90%.
So it's amazing. It's an entire ecosystem look like. Again, I think this is what I love about this whole discussion, because as many of our participants would appreciate that primary care is not just a traditional primary care model, see primary care and then, but this is a world within, an entire ecosystems, and every model has its own ecosystem. Continuing that discussion, I would love to kind of now talk to Dr. Farrago, Douglas Farrago, because he's been founding member of one of another amazing model, direct primary care model. So Dr. Farrago, tell us more about this model and the current barriers you guys have.
Well, direct primary care is not really founded by me. It was not really reimagining primary care. It's remembering primary care. It's remembering what we were supposed to be as doctors, right? We're supposed to be there for our patients, spend time with our patients, and not run them through a turnstile, which is what American medicine has become, industrialized medicine. And so we became, this is about relationships, not transactions. And so the only way to do that, direct primary care is now using this subscription or membership model at an affordable rate, a very affordable rate, sometimes $50, $60, $70 a month, or cheaper when it's a family, so that we can have a smaller panel and we can understand and see and know our patients. So the problem that we have now in this country is there's a third party involved that gets involved with our care that has no business being involved with our care. You don't go to a jewelry shop and buy a watch and not know the price, and 3 months later get a bill that's $20,000. That just doesn't happen. So with direct primary care, you know what you're getting paying every month. We try to, there's no co-pays, there's no office visit fees. We spend 30 to 60 minutes with patients. The procedures are free. We use technology as much as we can use it, whether it's point of contact ultrasound to telemedicine. We were never bothered by the COVID-19 because we were using telemedicine all the time. There's no cost for us. When we talk to patients, there's no coding, so there's no billing. So when people would call us or email us or video us, we were using that already. So I think that this is a growing, massive, revolutionary movement where we need to get rid of those groups that are affecting how we care for patients. One being the insurance company. That's in this country, you never see a commercial that says take 15 minutes to save 15% on your health insurance. It doesn't exist. There's no competition. They rule it. And the only way to get away from it is doctors need to push away. And that's what's happening in direct primary care. So our barrier is in the same vein, right? Patients are addicted to health insurance, thinking they have to have it. They're on the teat of health insurance, and they do need something for catastrophic care. We need some type of safety net. But for daily care, we can use the movement of Amazon and other things where you shop around for things. We do that in direct primary care, where we help patients get the cheapest MRI, the cheapest medications. We as doctors who have time are advocates. And so the quality metrics in that, which is a garbage thing that's used by insurance companies, one thing they'll never measure is time with patient. And we have time with patients as direct primary care, hence another reason why they hate us. But that's a good thing. Patients love us, and it continues to grow at an astounding rate. And I'm proud to be someone who represents that. If people want to know, DPC News gives all the information on a regular basis about direct primary care.
Thank you, Dr. Farrago. We'll come back to talk more about the barriers and how technology in our second round of questions. So I'd like to move to the, as mentioned, the finance, and obviously everything runs, that's kind of the fuel of the whole ecosystem. So we have Monique Mrazek. She is representing IFC, the World Bank, is one of the largest organizations. So Monique, being one of the largest global development institutions, the IFC, the World Bank, which invests heavily in healthcare sectors. Tell us more about the IFC initiatives on the primary cares and different models and the barriers you guys are facing.
Sure, great. No, thank you for having me. So IFC, as you mentioned, is the private sector arm of the World Bank. So we have a part of our World Bank group that focuses on governments and the public sector. Where I sit is within our private sector group, where we focus on investments in private sector in healthcare and emerging markets. So we've invested a little over 7 billion now globally in healthcare. The bulk of that is in health service provision. The models, when we think about primary care, a lot of the models are still sort of hub and spoke models where you have primary care that's affiliated with a larger healthcare group and a hospital network. But increasingly, we've seen an emergence of outpatient care chains and specialty types of chains and clinics. It's interesting, the models that we're starting to see, I think we're sort of kind of link up to what the previous speaker was saying. If you look at a country like Brazil, which has, all citizens are entitled to healthcare for free. The challenge is that not all of them can have access. There's a limited capacity, and they also have a very active private insurance market. But that's private insurance has been primarily focused on inpatient care, and so in the last couple of years, you've seen an emergence of primary care or outpatient care solutions that have been trying to address the unmet need in that market, either going directly to the consumers or actually working with corporates and providing sort of B2B solutions, B2B2C solutions for patients in those markets. In terms of payment models, we see everything from direct pay out of pocket to membership type of models. Which is also another sort of payment models we're starting to increasingly see. In terms of specialty services, we've seen specialty types of diabetes care management solutions, eye care chains, dialysis chains. We have investments in several of these. And of course, over the last couple of years, even pre-COVID, we started to see a surge in the utilization of telehealth type models. Particularly because there's an unmet need in most of these markets. You don't have enough health professionals to address the growing demand for healthcare in these markets. You have a dearth of physical infrastructure, and obviously post-COVID, we've seen a surge of that, and we'll talk a bit more about some of the technology models. Sort of related to COVID, I guess we can say that IFC has also been really focused on increasing the amount of investment that goes to address COVID-related needs in these markets. We have a $4 billion facility, which is launched immediately, I think around March 2020, which has been really focusing on trying to address not just the gap in testing, for example, but also in terms of care needs. So primary care would be a particular focus there. I think the interesting thing is some of our markets, especially when you look at the private sector in these markets, there isn't always a culture of primary care. A lot of folks, especially when you're paying out of pocket, will just go immediately to specialty types of care. So there's also, I think, institutional focus, not just within IFC, but also the bank group in general, sort of re-engaging that focus of not just on catastrophic acute care, but really trying to address the needs in terms of primary care. But clearly we're seeing the use of technology as being really important to that.
Very nice. Thank you so much, Monique. That's great there. We'll come back to that specific barriers what IFC and facing with their network. So our last panelist with from the Dubai and Dr. Mazin Gadir. Dr. Gadir, IQVIA is one of the leading organizations in using healthcare data analytics and AI, artificial intelligence. Tell us more about IQVIA initiatives and projects in the primary healthcare.
Sure. Thank you so much, and thank you for hosting me today. Basically, in the Middle East, or we actually the regional coverage that we have in IQVIA in this part of the world is Africa, Middle East, and South Asia. We cover around 57 countries with a workforce of around 2,000. We have three focus areas. IQVIA AMISA, or the acronym we use for Africa, Middle East, and South Asia, covers life science, pharma and life sciences vertical, public health programs, and payer provider government. What IQVIA has been working on is on all frontal exploration, so working with pharma life sciences in different areas, such as technologies, services, informational offering. Public health programs, we're very engraved in working with the likes of USAID, Belinda Gates, NGOs, United Nations, WHO across the region. And then in the payer provider government is where we bring in the non-pharma business, basically the technologies that we have and solutions that we offer in the area of health informatics. Just to give you a quick summary of what we're working on specifically, we are in the digital health transformation journey of multiple national programs in AMISA, participating in, for example, the digitization of the claims post office on a national level, where we've deployed our claims platform and post office across 5 different countries. And that's an important digital transformation initiative across many nations here by digitizing the health financial post office or the health insurance claims platform. The other area that we've been working on is basically the huge drive towards health information exchange in the region. And that touches specifically the primary care layer and tier that has been completely reactivated across Africa, Middle East, and South Asia due to the importance of tier 1 of the defense mechanism in the healthcare ecosystem. And that's why the focus on growing primary care, sustaining primary care, started with building the enablers. And we are one of the enablers, we as in the digital technology vendors community, by bringing in the digital transformation tools. And we've been working on, for example, digitizing, building our clinical information systems or deploying our clinical information systems across the primary care, as well as driving the digital in addition to driving digital health transformation, we are also looking at the different reimbursement models, because now there is also a huge drive towards value-based care, where a lot of utilization focus has been shifted to the primary care. Post COVID-19, the focus has always been bringing health out of the hospital environment, and again moving from sick care to community care and family care and individual self-care. So again, and that has initiated a lot of the initiatives we participated in, from looking at the way we process claims to the way we digitize medical and healthcare workflows, to also bringing in mobility solutions and deploying personalized medicine from the sense of Internet of Medical Things, and bringing in data management tools to try and enable the accumulation of that. Yeah.
God, it's a complete ecosystem for technology. Amazing work there. Okay, so I'll think start with the second round of discussion. My only request will be, I mean, I wish we can talk on this for hours and hours there, but my only limitation is the time, and of course, your time is so valuable as well. So maybe we just only have probably 2 minutes for each of the panelists to just briefly talk about the barriers and then the solution for the barriers there. So with Dr. Wohlfeiler, I'll come back to you, especially you mentioned about the barriers, for example, the medication adherence and mental health there. How do you envision technology helping or in the next 2 to 5 years roadmap for EHF would be?
Yeah, I mean, in my opinion, technology is absolutely critical to the goals of the Department of Medicine at AHF. I think that, like a lot of places, we had just started to kind of dip our toe into telehealth, and then COVID hit, and suddenly, we had to have a telehealth solution. So there's been a rapid expansion of that, and I think that we've realized the power of it. And I mentioned that one of our big concerns is retention in care, and the issue about retention in HIV is that we cannot cure HIV. So if patients stop their antiretroviral therapy, not only are they going to have their HIV start to progress, but it becomes a public health issue because they're then able to transmit to others. So keeping patients in care is really critical, and so some of the things that we're looking at now are patients who are showing behaviors that we know can lead to falling out of care. We're trying to use telehealth to re-engage them, make it easier for them than having them physically come into the office. We're doing things like patients who no-show. We're trying to immediately reach out to them and offer them a telehealth visit on the spot, or patients who call to cancel their appointments, things like that. But beyond telehealth, we're also looking at other that will reduce barriers between the clinic and the patient. I mean, we also believe very strongly that, and studies actually support this, that the relationship between patient and provider is really critical to keeping patients in care and keeping them adherent. So, we're looking at things like a better patient portal. We're looking at communication platforms that would, one of the things that makes me crazy, and I know it makes patients crazy, is to have to go through a big phone tree when you call in, and then you can never reach the person you want. So we're looking at platforms where patients can directly call a cell phone that staff member in the clinic has, and have much more direct communication. The other thing that we're really doing a lot of is we've been working for a number of years now with a company called Epividian, and we work with them to develop a mobile app for our providers. And we've created different modules within it. So for instance, we have a huddles module for our morning huddles with the entire healthcare center team. It lists all the patients coming in. It highlights care gaps that they've got. We've got a retention and care module that sends alerts when patients hit certain criteria that we know might mean that they're on the road to falling out of care. We've just most recently created there's a new HIV treatment that was recently approved that is once a month injections rather than taking daily pills. But it's very important that patients be adherent. There's a 7-day window around getting the shots, and they've got to get their injections monthly within that window. So we've developed a module just for that to alert us if patients haven't made an appointment or if they're not within the window. And so those are just some of the ways that we're doing it. I think it's the future to everything for us. So.
Excellent. And I think that a lot of technology can do also to bring the specialty care, because a lot of these patients who, as you mentioned about mental health, and I'm sure the HIV patient, I'm a nephrologist myself, but the kidney problem is very prevalent and heart disease there. So I think that definitely there's a lot of more that ecosystem will. I'll come back to Dr. Julia Skapik there. How are you seeing the best use of technology and FQHC? Because FQHC also a lot of those challenges, patients, as you mentioned, do not have maybe a smartphone there, and then the other barriers there. What's the role as a national leader and director there, where FQHC is going utilizing technology in the next 2-3 years?
Yeah, so actually, FQHC patients really respond well to text messaging. It allows them to sort of semi-synchronously communicate with the health center, provides them with a low data connection. So many health centers have ramped up their text messaging programs to help sort of check in with patients, remind them of their appointments, but also to sort of ask questionnaires. I know a number of organizations had used text messaging in order to monitor COVID-19 patients. Obviously, we don't want those patients out in the community, but it was helpful for them when they're managing their day-to-day activities. I actually find that, we are in the process of moving towards developing some virtual care models. I think it's a mistake that virtual care is just in-person care over the phone or over a video. It very much shouldn't be that. And there are obviously some things that really should be executed in person, and some things that are probably not necessary at all to do in person. So we're trying to figure out, how do we integrate both the in-person touches and the remote touches? Because what we're seeing is, if we can actually talk to our uncontrolled diabetics and hypertensives every week, we can have many more opportunities to make a change. And I think the traditional model of care, where we see the patient every 6 weeks or even every 3 months, there's too many missed opportunities. Those care gaps are just really impossible to fill. And so I think we're trying to be creative with our use of technology without imposing requirements on the patients that actually exacerbate health disparities, because technology can certainly be a driver of health disparities. I think it can also be something that helps to alleviate those. I know some of our health centers have done things like they buy phone cards or data cards to help their patients be able to use those to access. But I think the real movement is going to be giving devices to the patients. It is easy if they're already preloaded with some things that they need to monitor their health and to reach the clinic easily. And it sort of circumvents a lot of those other challenges that we see about the patient getting and maintaining access. We have a lot of patients who will have a number at 1 week and then they won't. Go ahead.
Sorry, what do you guys do for specialty care? So patients needing special.
Yeah, so I was going to mention that. So
yeah, sorry, go ahead.
Many patients, even with Medicaid coverage, can find challenges in finding specialists that will accept their insurance coverage. But we do have that significant proportion of uninsured patients who basically have no access to specialty care. In the past, health centers have tried to sort of negotiate individual agreements for low-cost services from individual specialists. But I think there's really an opening here to move towards having more specialty monitoring and consultations via telemedicine. Specifically, RFQHC is looking at that now, and I know there's some strong interest in seeing if we could get on a national level the programs that support things like 3,4-DB and Ryan White, if we could have a similar sort of access to specialty care kind of approach.
Perfect. Good. I know we just going to start a service with one FQHC, and we'll see how it goes. We'll discuss. Thank you. Yeah. So moving to Dr. Farrago real quick, you mentioned about the barriers. Of course, you mentioned about the benefits of DPC, but still, I mean, a lot of things which patients need insurance for, and one of them is finding the ancillary services, and I mean, God forbid if they need hospitalization there. What do you think the role of technology in you foresee to solving that barriers for patients finding that care which DPCs are not able to provide, like maybe specialty care or
Well, I think first of all, the payment model for direct primary care, which is a subscription model, we have all levels of people from no, to have not much income to higher income. So it's not for a subscription model. It's not for the rich. It's not concierge care. It's a very affordable model. We as physicians and direct primary care really value that relationship issue and knowing our patients. I agree with the past speakers. Everything doesn't need to come into the office. There's no reason for every issue to come in the office. And that's why we've always used texting, and sometimes days after a visit, I used to text patients, how is your symptoms doing? That never happens anywhere else, but our office did that all the time. So yes, you can't replace the physician. And I think the important part is be able to combine both the technology and those in-visits so you have a more complete picture of that patient. So you have less hospitalizations and less specialty visits. Now, what do you do when those occur? Well, we depending on situation, if they have insurance, they may have to use who they have to go to, but we speak with local specialists who will give a cash price in this country so we can keep the price down, whether it's for MRIs. I could tell you where in this area where the cheapest MRIs are, the cheapest medications. I could tell you the cheapest visits for neurology. I can tell you there's an online rheumatologist that we use. And so we know as an advocate for our patients, because we have that time. Here's the thing. What FQHC is a much needed service, but they are inundated with patients. So it's just harder for them. They have to figure out different ways to see all those patients. I worked in FQHC for 15 years. This model with 600 patients in my panel, 700 patients versus the normal 3,000, I definitely have a more complete view, and I definitely tie more ends up and have time to look things up versus tossing every referral to a specialist because I have no time to dig into it. That's what makes direct primary care so special for the patient. They become family to us, and we treat them like family. That's nowhere else does that happen.
Thank you so much for that. Now, coming back to Monique, yours obviously such a big portfolio in IFCs. What's like the vision of IFC leadership for the next 2-3 year roadmap in terms of the digital health, specifically for primary care?
Yeah, and as mentioned earlier, there's such a lack of sort of physical infrastructure, human resources. So we see technology as playing a huge part in terms of delivering that care. In pre-pandemic, we were already seeing a lot of models emerge in different markets that would offer, telehealth, maybe linked to sort of, online pharmacy, for example, as sort of, it was a free service and they would generate the revenue mainly through that. I think post-pandemic, I guess we're not post-pandemic, but as a result of COVID, a number of these health providers that were traditionally bricks and mortar were really sort of dusting off their plans. The same as it happened in many developed markets. And so you've seen this sort of transition to traditional, bricks and mortar health providers also now providing sort of virtual care options. We actually have just launched a program called DigiHealth in Asia, which is actually working with large traditional health entities to introduce a variety of digital health tools into their operations, including telehealth, to expand their reach, especially into maybe peri-urban or into rural areas, for example. It's also, I think, we see it as a way to sort of enable healthcare workers that maybe it's a less skilled healthcare worker, but you're now able to sort of have skilled assets in a central location who can then work with that healthcare worker and reach patients in a completely underserved, especially rural area. Right. So we see it as really important. Obviously, there's still a lot of barriers and challenges. I think regulatory is a huge one in our markets. Many markets sort of opened up the possibility to do telehealth during the pandemic. But in many markets, that regulation remains very gray or non-existent in some way. And I think from a patient perspective, it's very challenging when one platform maybe tells you, well, I can't give you a diagnosis, but I can give you a medical guidance, where the next one gives you a diagnosis. It can become very clear and very vague in a lot of these markets. So there's a need, and institutionally, we're working with a lot of governments now, sort of on the regulatory aspects around this. We see obviously a high penetration of smartphones in many markets, but the cost of data still remains very high. So the use of text or voice calls for consultation is not uncommon. And just generally within the systems, we're at a very early stage of the digitization. I mean, when we look at EMRs, the penetration is still incredibly low. So there's still many challenges that we have, but I think as for us institutionally, we have a priority now to look at how do we, not just within healthcare, but broadly across various sectors, work with countries and governments to help facilitate for the digitization in the economies.
No, I thank you. I agree. I think one of the biggest challenge because we have operations in international markets as well. One of the biggest challenges is the utilization of the electronic health record. We're just running out of time. Very shortly, I'll defer the question. I'm not too, because I'm not too. You would like to kind of proceed with further what we have on the schedule.
Sure, thank you. Thank you, Dr. Ahmed. So this conversation so far has been very enlightening. And it has been a pleasure to hear experiences and the work being done in different areas. I would like to add that from our panelists, we hear a very common theme of bridging certain gaps between providers and patients. And also a term that each of our panelists have shared today is, they've mentioned the term relationships. And I think that is key to any discussion going forward. So as we aim to transition from purpose to action, the shift towards shared values and responsibility, specifically corporate responsibility that links social and environmental initiatives is also key in mobilizing and of course in accelerating momentum for change, and in efforts to show and not just tell. Our aim is that this forum centers on solutions approaches to healthcare accessibility, and that it centers on a framework that provides an opportunity to align, corporate global public health and development goals, and also that it centers on this idea that there is a shared responsibility of advancing health and prosperity for all. And with that, I would like to yield the rest of my time actually to Dr. Ahmed and ask him to switch his moderator hat so that to that of a provider with his own experiences in his space, to share possible ways for us to, bridge some of these gaps that we've heard today in our conversation. So I'm kind of putting you on the spot there, Dr. Ahmed. So over to you.
Thank you, Ameena, and thank you, all panelists. It was such a great discussion to the insight there. So the American Telephysician, that's a key host and the co-host for this, and being a stakeholder. Started our journey about 5 years ago, and being a physician-led organization, exactly, realization of the whole challenges what all the patients have, what are the challenges our healthcare system is facing, not only in the US but also in the international market, and also what are the challenges, the key players, whether those key players are what patients want. They want affordability, price transparency, more convenience, Amazon effect. Whereas our physicians want more flexible schedule, being burnout, that's a big challenge for them. On the other side, the healthcare facilities, they're constantly, what I call, it's kind of a tug of war between the payers and the hospitals, and working in the different clinical settings myself, and also in the international market, we see all these kind of challenges there. What exactly is happening currently in a traditional healthcare system model? I think the focus is about the patients. It's a patient journey. Their challenges are the kind of, should supersede all of the other challenges there. And the model of the care, if it's centric around the patient care and their journey, we American Telephysicians think, when we brought this model, that this is the model which probably may be able to answer, if not all, most of the barriers in the question utilizing technology. So instead of patient traveling, right now the patient has to go to the hospital or clinic, find the care, and then see a doctor, then they write orders, and then they find whether it's a DPC model or FQHC, or the AHF model where, the mental health there. So obviously they have to find that whole model care. I think what the future is going to be, how patient can get their care at doorsteps, not necessarily the care at their home, but also if they still have to go for some of the care outside, it should be easily navigated there. So this is what we call a smart connected healthcare model, which is essentially connecting patients at home or in the nursing senior living facilities, connecting them with the services which can be delivered at home, their doorstep, which means an online doctor, home diagnostics, remote patient monitoring, a treatment home. That's one vertical. The second vertical is still pretty the gold standard, where patients will eventually still go to doctor's offices because they may have to go for procedures or big diagnostics like MRI, those things which cannot be bring at home. But at least the journey of the patient to find those services near them with price transparency, that is one of the big barriers, the key there. And of course, when they're in the hospital, especially if the hospitals are in the rural area, again, the specialty care is what's there. So what we envision that in order to do that, this was kind of a big 360-degree approach when we started this company there. How can build this one platform which can integrate all those healthcare models and also connect those, all the healthcare facilities, but it also should have data analytics, family engagement, price transparency, all these things there at one platform there. So keeping in mind there, we built one of our platform in Smart Clinic, which is core engine for that. And that is not only just a telehealth, it's the EMR with integrations, patient's reminder, patient portal, remote patient monitoring. And then utilizing that, we also launched our marketplace project, first actually in Pakistan, where we launched the Shifa for You, where patient can find all the healthcare services. We brought this in the US market. We contracted with the Quest Diagnostics, so 900 radiology centers. We have listed all these specialty care online consultations, like if you need, patients need online consultations, rheumatology, any specialty they can find there. But now we're also moving that, okay, if you want to see a doc patients in the office, we can actually listing them so they can make the schedule appointments more easy. And most importantly, the family engagement, their family members can do on their behalf. If they are not tech savvy, the family members can do that, because that's something very close to my heart, because my parents, I know they're not tech savvy. They live in different part of the world there. This was something which was there. And then utilizing, I think the most important thing was our physician services. We as a company now utilizing technology, bringing our multi-specialty physician services with establishing on-site teleclinics, whether it's the FQHC or DPC, where we can actually have people who are not tech savvy, they still come to doctor office. We can do that. Those who are tech savvy, they can have access directly through their smartphone or laptop. And most recently, we also started this physician-to-physician services line, specialty service with primary care. I think hugely helpful for the patient there. And keeping that in mind, now that's exactly what we're building. The next phase is specialty care. We are launching now specialty care because we think that it's becoming now very specialized care. Like for example, NeuroX is going to one of we lost it last year. All the multi-specialty neurologists now able to see patients in the senior living facilities or clinics at the nursing home there. And those resources which are required by the physicians and the patients, they are the one there. And we're very, very humble and excited to be kind of the part of the United Nations and this initiatives there. And obviously expanding into different markets, not in the US, but the international market also. So looking to kind of, working with all the big players, I guess all the important players, that's exactly what we're looking to expand. With that, I will, I know it's running out of time. Sherri, just we have some closing remarks. I'm so sorry, I know we just ran out of time there, but thank you for your patience. Over to you, please.
All right. Well, we knew time would be our enemy today. So I would just like to, in closing, first thank Dr. Ahmed for moderating this event and, helping guide this conversation. And I'd also like to thank Dr. Ameena Zia, who's the founder and CEO of Blue Ridge Consulting, for her dedication and work with the United Nations. Today, we focused on integrating technology in an effort to provide access to quality, these essential healthcare services. And of course, this is in line with United Nations Global Goal 3 around health and well-being, and specifically the Target 3.8 around this accessibility to these quality services. So in that vein, what we set out to achieve today was really threefold. First, we wanted to help broaden our understanding of the primary care model in healthcare. We also wanted to examine collaborations between stakeholders, and I think you heard that today, in reconfiguring access to this whole healthcare ecosystem, and there were a lot of examples of that. And then finally, a renewed commitment to the adoption of technology-driven approaches for sustainable healthcare development and implementation. And I think you heard all of that addressed today. The people that you heard from are not only stakeholders, but they are thought leaders in their respective spaces, and we really appreciate their expertise. This team they are instrumental in reimagining the model, beginning with primary care and helping to build a better healthcare ecosystem. And, you know, as Ameena had said, advancing progress of sustainability goals, which is critical as we try to recover from this COVID-19 pandemic that we're still dealing with. We all hope you found the discussion educational and inspiring, and we certainly hope that you'll follow and embrace the work that these leaders have begun. Thank you all so much for your interest in this important topic and for joining us today. And we certainly hope to connect with you again very soon. Thank you all so much.
Thank you so much, Sherri. Thank you, everyone. And last, Dr. Gadir, I'm so sorry, I think we missed one part of your question there, but thank you for your patience. Thank you so much. All right, take care. Bye-bye.
Thank you, everyone.
Okay. Bye.
Thank you. Bye-bye.
Bye.